Every minute, someone's life takes a terrifying detour, not down a dark alley, but into the sterile, bright halls of healing. They walk in seeking care and find themselves plunged into a nightmare. Most malpractice claims in hospitals are related to surgical errors, whereas most claims for outpatient care, which accounts for more than half of the paid malpractice claims, are related to missed or late diagnosis. Now, before you raise a pitchfork at every white coat you see, let's be clear. This isn't an indictment, it's a revelation. Because the truth is, any provider, any nurse, any human being capable of brilliance is also capable of a mistake. This is about understanding why and using that knowledge to build a safer future for every patient who walks through those doors. Scrubs and Subpoenas, Tales from the Witness Stand, a podcast where we'll peel back the sterile sheets and delve into the real stories of medical malpractice. Each episode, a cautionary tale, a blueprint for change, a reminder that even in the darkest corners of human error, there's a light. The light of knowledge, the light of empathy, the light of a future where healthcare becomes not a gamble, but a guarantee. So join us as we dissect the mistakes, illuminate the flaws, and ultimately learn to heal not just bodies, but the very system itself.
Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello and welcome to another episode of Scrubs and Subpoenas, Tales from the Witness Stand. I still really want thunder when we say that, so maybe we can ask the production team about that. But anyway, welcome back. Dr. Miller, how are you? Thanks for joining me.
I'm very well, thank you. Thanks for having me.
Absolutely. And to all our listeners, thanks for tuning in to another episode. We're excited to have you as always. For those of you that are tuning in for the first time and didn't listen to our wonderful intro that we have, remember that we're going to talk about real medical malpractice cases, right? Breaking them down, breaking them apart, trying to understand what happened, maybe why, where, when, and the takeaways that we can use in our own practice just to be a little bit better, a little bit safer, right? A little reminder of what we're doing and why it's so important. So with that said, I'm going to turn it over to my very esteemed guest, Dr. Miller. I'm very excited about this story.
Well, good morning or afternoon or whatever time it is. I honestly don't remember, but I guess for anybody, it could be any time zone, anywhere. So this case is the psychiatric mental health nurse practitioner. Ooh. Is the person that is being, that is the person against whom the complaint is made. So like we usually do, I'll tell you a story. I'm going to try not to be too schizophrenic about it here, but just to try, and I'm reading from my notes. I realized later I probably always look like I'm looking down because I'm reading from my notes, just because I mean, not just my notes, but like copies of notes from the chart, because I want to give everybody all the real info and not sound like I'm slanting it to my opinion. I mean, at the end, of course, I have an opinion. That's what I get hired for in these things. But it is really important to take the facts of the case at hand and look at them in an objective way, because any expert witness, it doesn't matter whether the plaintiff retains you or the defense retains you, you can't go into it with that perspective. You have to go into it objectively. And if you read a case and you cannot support the position of the person that retained you, then you have to tell them that. And I've done that too. There have been times where it's like, look, this person just didn't do anything wrong. I can't support that. Or, oh, like this doesn't look, this really, I can't defend this action. So we look at it objectively and then we can form an opinion. So this is a story about a 34-year-old man who was admitted to an inpatient psychiatric facility. And the nurse practitioner who ultimately was managing his care during the events that mattered. So to read my notes to you, the patient had long history. He was 34 years old at the time of events, but he had numerous psychiatric diagnoses, numerous episodes of psychoses. These first became apparent in adolescence. So he has a 20-year history of psychosis, of psychotic episodes and numerous psychiatric diagnoses. He had been hospitalized numerous times throughout young adulthood, repeated documentation of aggressive behavior, interactions with the criminal justice system, including incarceration. He had been on probation. So his diagnoses led to criminal behavior, and there was a long established pattern of it. The diagnosis he carried to this admission were schizoaffective disorder, which is a combination of schizophrenia along with a mood disorder. It could have been bipolar disorder or a major depressive disorder. Oh, it was bipolar type. So schizophrenia, bipolar disorder, obsessive compulsive disorder, post-traumatic stress disorder, and substance abuse dependence. Now, sometimes, just like in any other setting, sometimes these diagnoses just sort of get thrown at people in acute circumstances, and they may not all be current or all actually be accurate or supported, but those were the diagnoses that were on the chart. So what everybody knew for this patient coming into this particular hospitalization is that he had a long history of being aggressive and violent and criminal convictions and incarceration and a variety of both psychotic and neurotic diagnoses as well as substance use. He also had a documented history of suicide attempts. He had been convicted of violence, including convictions for domestic violence with the use of a weapon. So anyone who approaches this patient has to be aware of that, because safety first. It matters. So the patient at this time, he was 34 years old, and on the events that matter, he was admitted to a behavioral health center as a direct transfer from a regular hospital. So apparently he had some outburst or some events. He was taken to a hospital, and then they sent him to the behavioral health hospital. He had very recently been discharged, like 3 months prior. He had been discharged from an involuntary hospitalization following a court-ordered conditional extension. So the court ordered him into care, and then they allowed him to be released pending very intensive, aggressive outpatient follow-up and monitoring by the criminal justice system. So that's how he happened to be home, even though he had this very recent history of violent behaviors and that were attributed to psychosis. So there's a lot going on there. Anyway, he went home with his mother. His condition rapidly deteriorated, and then he was sent back to behavioral health 3 months later. He failed to demonstrate improvement, and then he was sent to the place where he is now. So that's what's going on. His admission history and physical examination at that point documented an uncooperative patient with deteriorating psychoses. So that was his condition on admission. So because I feel like I sound schizophrenic, let me just pull it back for a minute for everybody who's listening. For 20 plus years, this man has a history of psychotic episodes, of aggressive episodes, of OCD and substance abuse and criminal behaviors. He had been in and out of inpatient facilities on and off for years. He had had suicidal attempts, but most recently, he had his most recent conviction. And then as a consequence of some judicial mediated supervision to try to ensure care, he had been allowed to go home with close follow-up and, following by probation and mental health. And he was with his mother for a couple months, but he rapidly deteriorated and wound up back in the hospital. And when he got to the hospital, he was uncooperative. He was psychotic. He reported that he had been hearing voices telling him not to take his medication, that the voices sometimes told him to kill himself. Oh, no. We know he has this history of aggressive behavior, and in this admission, it was documented specifically of kicking doors, punching walls, throwing a bottle of water at the staff, becoming fixated on some of the female staff members. So that's where he is today in the hospital, and we know that he's on probation for domestic violence, for assaulting not a wife, but a family member. He had held down his sibling and put a knife to her throat. Oh, so that's the circumstance when he's in the hospital right now. So on his admission, his physical exam documents that he is agitated. He has an order for restraints as needed. He had been non-adherent to his medication regimen while he was with his mother, which is, of course, why things deteriorated. So on this admission, they resumed his medications, which included topiramate or Topamax, which is anti-epileptic medication that I'm kind of surprised. I don't know what exactly it was for. I mean, sometimes we use those anti-epileptic drugs as mood stabilizers, use them for anxiety and depression, but Topamax really isn't one of the first ones. But anyway, he was on that. He was on trazodone, he was on clonidine, and he was on Invega intramuscularly, which is the antipsychotic.
Wow.
At the time of the admission, there was also a PRN protocol initiated for Haldol, Cogentin, Ativan, and Benadryl. So for those of you who don't routinely
I know
work,
what that cocktail mix is.
for those of you who don't routinely work with a psychiatric facility, I mean, Haldol is a first generation antipsychotic. It's funny, it's got this reputation of being, oh, Haldol, but it's a first generation antipsychotic. I mean, it may have side effects like sedation, which in this case we would like, but it does control psychoses. I mean, the only reason we don't like to use Haldol so much now is because of the adverse effect profile and the sedation. But in that circumstance, you want to capitalize on it. The Cogentin for the extrapyramidal effects, the Ativan is the benzo for, to immediately calm somebody down, and then Benadryl as an added agent to promote calming. So that was the PRN cocktail. Just like sort of like when you admit somebody to all sorts of units, there's standing orders that are commonly used, and this was that. So he was admitted. He did not respond well to treatment. He obviously didn't like being there. He didn't want to be treated during his hospitalization. But the documentation, it appears that he remained isolated. He was uncommunicative, no insight into his diagnoses. I mean, many patients with psychiatric diagnoses, once you acutely calm them down and you get past that acute agitation and psychosis, which Haldol and Ativan will do, they often do recognize that they have psychiatric diagnoses. I mean, they might hate their medication. They don't like the side effects. But I would say the majority do know that they have a condition that needs to be treated. They just don't like it. But there are a fraction of patients with psychiatric diagnoses that lack insight. There's actually there's a diagnostic term for it, and they're the hardest to treat because lacking insight just makes it impossible for them really to engage in therapy, and they're always very resistant to taking medication. So this man was like the hardest of the hard to manage. From his admission through the next 10 days, nursing notes consistently document that the patient remained isolated, not participating in group. On one day, he presented to the nursing station demanding medication for GERD. He then became agitated and symptomatic, and he had to get his protocol, Haldol, Cogentin, Benadryl, and Ativan. 3 days later, they attempted to have him see the psychiatrist in the facility. The details aren't documented, but apparently the patient ultimately refused to leave the office and he had to be carried away in a chair. Now, he is a 34-year-old male over 6 feet. I think it was about 250 pounds.
Oh my God.
And he had to be carried out. Again, he was medicated with the cocktail of Haldol, Benadryl, and Ativan. Aside from those two events, when he went to the nursing station asking for medicine for GERD, and when he refused to leave the psychiatrist office, the nursing notes really just consistently document a patient who is isolated, no proactive contributions to care, no participation. Now, in an inpatient psych facility, there's always group that they want people to go to. There's a variety of ancillary services that will, social work usually comes in to try to work with you, some as indicated, OT, PT, all that kind of stuff. And he just wasn't interested. So he was in the hospital for a total of 17 days. And all of these things happened about halfway through. So then on the morning of the 17th day, there was documentation that the patient ate breakfast in the dining room, which was unusual. But then after breakfast, he went back to his room, slammed the door, and was unresponsive to the psychiatric technician's query as to his well-being. That's the way it was documented. Shortly thereafter, the patient comes out, goes to the nurse's station to apologize for his behavior. Then he goes back into his room. Between like 8:30 and 9 in the morning, approximately, there's documentation after he apologized. So he went to breakfast early. He went to the dining room, which is odd. Then he went to his room and slammed the door. Then he wouldn't respond. Then he came out to the nurse's station to apologize. Then he went back in his room. And shortly thereafter, staff heard a loud bang in the room. And when they went into the room, the patient was documented as, quote, out of control, kicking garbage cans, the linen cart, throwing his own feces at people.
Oh, my God.
Notes further described that he was flipping tables and chairs. Documentation indicates that he attacked a staff member. So At approximately 9 a.m., 911 was called by facility staff, and an emergency was called in the facility. So the patient was contained by staff in a prone position. Now, remember, he's violent, he's kicking, he's big, he's turning over tables, he's throwing feces. So they call 911, and facility staff managed to keep the patient in a prone position pending the appearance of someone that could appropriately restrain him and then take him out in the ambulance. So everybody getting the picture here, we have this clearly unstable, violent, dangerous patient who is now just really started acting out probably in a psychotic way. Several staff members, he's already attacked one staff member. Other staff members are holding him down, and they're just waiting for an ambulance. So when all of this happens, of course, the provider on call, the ranking provider on call, this was a Saturday morning, is going to be called to the scene, and it was the APN. This APN didn't know the patient. She just covered weekends there in this inpatient psychiatric facility, and so she is notified that they have this, dangerous situation, and an ambulance has been called. So she comes to the scene as well. So when she gets there, she, tells them to go ahead and give his protocol, his Haldol, Benadryl, Ativan, and Cogentin. The progress note reveals that the patient remained agitated. Even while all this was going on, he was trying to, get away from it and being resistant to his medication. So he was restrained in this position, continued to struggle violently. Then he was given his medication, and the ambulance staff arrived, and the patient stopped struggling. When he was turned supine, he was found to be apneic, from prone to supine, he was found to be apneic. 911 was already there. EMTs were already there, and they commenced cardiopulmonary resuscitation for about 40 minutes when he was finally pronounced dead.
Oh, holy crap.
So, horrible story. Horrible story.
Oh, shoot. Yeah.
So can you guess? So I said the APN, this poor soul who didn't even know this patient, just got stuff to probably go do her weekend, roll, make a few extra dollars.
I know how to
she goes in, and this happens on a Saturday morning. So any guess what the complaint against, any guess what the complaint against her might be?
That she ordered that while he was prone? Like she snowed him out and made him go into arrest?
It was a stretch really, but the real, this is all on video, by the way. There's video evidence of this, and there's people milling around. There's several staff holding the patient down. There's other staff members. Of course, there's patients. They're trying to get them out of the way, but there's patient watching. And then the EMTs arrive. So there's the ambulance staff. There's the nurse that the patient assaulted, and she's sitting there. She needs care from the EMT providers as well. I mean, she was okay, but she had a pretty serious gash on her face or something. I think they were worried about a fracture. So there was a whole lot going on. And the APN was the ranking person on the scene. That's, person like the nurses, the tech staff, this is who everybody's going to look to for their orders and stuff. So as you look if you look at the scene on the video, it looks a little chaotic, not overtly, but definitely this is not something they're really accustomed to. I mean, you might think in an inpatient psych facility you would be, but not really to that extent. And this is a big guy. The primary complaints, the complaints that they lodged against the APN was that apparently at one point the patient said while he was struggling, he was prone, he was struggling, he said, "I can't breathe." The APN in her deposition said she didn't hear it. He said he can't breathe, but then he kept struggling. So at that point, he was breathing enough to struggle against 3 different people holding him down.
Yeah.
And then later on, a few minutes later, again, he said, "I can't breathe." And she heard that. And you can see in the video, the head turn. And so when he said that, she instructed the staff to turn him over.
Yeah.
And then when they turned him over, he was not breathing. So the complaint against her was that she didn't intervene soon enough when he said he couldn't breathe, and that apparently on autopsy there is some suggestion that he was over-medicated. I don't remember the details because at this point it didn't matter to me. It wasn't, relative to what I was being called for.
Right.
But there was some concern that he had been over-medicated with the benzo. like the wrong dose.
And he
And
was
so
arrested.
the complaint against the MP was that she ordered that without assessing the patient first, and that she didn't go into the medication room and watch the RN draw up the meds.
Surely you don't mean assessing while he's thrashing about. Surely not then. Am I assessing anything? My assessment is he is thrashing about.
That was the assertion, that she ordered the protocol without assessing the patient.
Well, here's an assessment of a man who's clearly having a crisis right now. Oh
And
my
he's dangerous.
gosh.
He's dangerous.
Absolutely.
I don't know how much assessment you need of somebody that needs 3 people to hold him down.
And what else could you assess? Like, honestly, what would you assess in this scenario without putting yourself at risk? And
I don't mean to laugh. It's not funny. And the patient died, and that's not funny at all. But I'm just trying to imagine, like, to administer Haldol and a benzo, what would you assess? In a perfect world, I guess their mental status and their vital signs. But again, you're not going to get vital signs in someone who, remember the history, the course of the events, and all of this, of course, is provided to her as she's standing there. She's standing there, and the nurses that know the patient and are familiar with the chart are sharing the history. He's got a 20-year history of intermittent psychoses, violence, criminal violence, assault with a deadly weapon. He has assaulted, staff. He had to be carried out of the psychiatrist's office. That morning, he got verbally abusive with the staff. He was flipping carts, flipping tables, throwing feces, had to be restrained. I mean, if 3 people are holding him down, what reasonable standard of care would expect for you to say, okay, everybody, let's get his blood pressure before we get, it's just impossible. It's ludicrous.
No.
Like this is what's so disturbing about our system. I mean, I totally do believe in when someone really deviates from a standard of care and the patient has a poor outcome, that there should be a remedy for that. I mean, I have testified to support plaintiffs when an MP really deviated from standard of care and should be held accountable, and the patient should be made whole. But I just look at this and go, who could ever? Now, in this case, I am happy to report they did not have an NP for the plaintiff. I don't know if it's because they couldn't find one. Maybe just everybody they contacted had some integrity. They had a physician opining about the care of the MP. We've talked about this before, like how slanted the system is. For every other malpractice case, only the same discipline can opine about that discipline. PT for PT, OT for OT, RN for RN, NP for NP, but a physician can opine on anyone. So that's just an anomaly of the system that really needs to be.
That's a different podcast we'll do after hours.
Oh, it's ridiculous. Like the assertion that the MP should have watched the RN draw up the meds. What prescriber ever in any parallel universe gives an order and then follows you into the med room? They're usually not even there. It's like a phone order, or they write orders and make their rounds and go away. Like no prescriber does that.
And the fact that the RN has a license means that she can do that or he can do that. I don't need you to watch me do it.
So the physician said that the MP should have watched the RN draw up the meds, and the physician said that the MP didn't intervene fast enough when the patient said he couldn't breathe. Now, I guess that's up, anybody can make that decision, but if she heard him or not and purposely ignored it, if you watch the video, you can tell, like, there was not even a flinch. There was so much going on. Here's the EMTs, the patient's thrashing, they're holding him down. The NP is being, given information by the RNs and the LPNs and the techs and stuff. So it makes perfect sense that in the midst of all of that, the first time he said, I can't breathe, she didn't hear it. Who knows what else was going on, like a stretcher rattling or whatever. But but then you can tell, like seconds later, you can tell that she turns her attention to the ground, like the patient calmed down. He was probably not breathing, but the patient sort of relaxed, things quieted down, and she heard him say, I can't breathe. And she did she had him turn him over, and they did right away. And unfortunately, he was apneic. But again, in terms of standard of care, how does this go different for an NP? For any provider? Like, what would you have done differently? Granted, to your point, I think
you're right. Like if you heard him say that he couldn't breathe, certainly you want to act on that, right? You want to act on that. If she didn't hear him, I can see how that can be possible in this type of scenario. And then I'm thinking if it was an issue with he had too much drugs, right? He had too much of the barbiturate. Couldn't they measure that in the autopsy to say yes or no, this was toxic level or not, to like have something like really like confirmational?
There was, again, that's not my area of expertise either. So I don't know about how fast things deteriorate.
Oh, yeah.
Like that's when time goes by and then when a body is not functioning anymore. But I remember from the autopsy report, it was not crystal clear, but there was some suggestion.
Yeah.
There was some insinuation, but that's its whole own science. I mean, I've seen plenty of cases where it comes down to, were they toxic on this drug? And there's different experts that have different opinions. And I don't know enough about it to say, like once, for me, the question was, should the NP have watched the RN draw it up? And I said, well, first of all, no. But further, are you suggesting that she should leave the patient and leave the events to go into the medication room? And even if normally she would have watched her draw it up, which is absurd. But even if you would have done it at that point in time, you would stay with the patient. So once that was my piece of it. It really wasn't for me to get into the different levels of drugs and how you break it down. So again, I don't know how it all shook out, but I know that the assertions against the MP.
So what happened with this case? Did this MP like go all the way?
Yeah, no, the MP that was actually dropped from that. It never even went.
Oh gosh, never even went.
It's like that's what happens in the beginning of a case. If I don't mean to make all attorneys sound bad. I'm sure that somebody who hires me one day will see Scrubs and Subpoenas, because part of their job is to research you on the internet and find out if there's anything controversial. So for anyone who might hire me one day, I really am sincere when I say not all attorneys are bad. There are two plaintiffs' attorneys that I have worked with several times. And they really they take good cases. And in fact, the one attorney, there was one time where he said, what do you think about this? And I said, no, that person didn't do anything wrong. There. And he respected that opinion. So these two, and I'm sure there are lots of others, they accept cases where there clearly is a deviation of standard of care. And in that case, absolutely, I'm glad that the patient has them to advocate. So we like to make jokes about attorneys, make jokes about physicians too, but there's plenty of good ones out there. But I forget why I went off on that train of thought. Anyway, in this particular circumstance, I don't know what else happened. I don't know if they pursued the business of, was the patient over medicated? Was there a meta or something like that? Right. But I just know from the perspective of the NP, there was no deviation from the standard of care. So it never, I know what I started to say was in the beginning, a lawyer gets a hold of the case. That's why I defended myself about lawyers. A lawyer gets a hold of the case, and it might be a good lawyer or it might be Better Call Saul. Remember from Breaking Bad,
Yeah.
So a lawyer gets a hold of the case, and typically what they do is sue everybody that ever came in contact with a patient as Jane Doe, John Doe, Jane Doe, John Doe. And then they bring in experts to review the case. And then as the experts review the case, it's like, no, this one didn't deviate, no problem here. And then different people get dropped out of the case as it progresses. And that's what happened here. Mm-hmm.
Yeah, I imagine everyone's just kind of just sitting, shaking, waiting to be dropped from a case in this type of scenario.
That's the heck of it. It is, it's scary. I mean, I have had papers served. I have been served in cases, but thank God, immediately dropped, never even went to, it's like the first time an expert reviewed it on that day at that time, my documentation was on. So it never, I've been named and then I've been, dropped as the case goes forward. And sometimes there really are good causes of action against people, but not all. We were talking about the MP. I don't know. I hope everybody watched the episode of the MP that evaluated the patient with the leg induration.
Yes.
Sometimes it doesn't get dropped until the very end, but
that's kind of
we do. So
wow, quite interesting. So wait a minute, who initiated this lawsuit? Was it his? I'm asking if it was his mom, just because I remember
his mother.
He lived with his. Yeah, okay.
His mother. Yeah.
Okay.
Oh, yeah. Whoever is their next of kin or power of attorney can initiate a lawsuit. And I've even seen cases drag on to where the patient died and then the person initiating the lawsuit died.
Oh my
and then
God.
their whoever's inheriting their estate like kept it going. I was involved with one suit for, oh my gosh, I can't even tell you how many years. It was like the patient lived for a couple of years, then the patient died, and then the patient's spouse died.
Oh my
And then
gosh.
somebody else took it over. We were waiting for the whole population to die.
Oh my gosh.
That sounded so wrong, but that sounded bad. But you know what I mean. It can go on like who I guess people inherit the rights to that or something. I don't know.
Oh, I don't want that. I don't want that.
It just it makes you afraid. It makes you afraid to see patients. But I'm telling you, do the right thing. You know, your care is consistent with standards of care, and document it.
Yes.
And really, I mean, you know, we read about the cases where, an MP was sued for millions of dollars or whatever, but the vast majority of the time that doesn't happen unless there really was a deviation and the patient should be compensated or made whole.
Absolutely. And I think it always comes down to that. And that's a great takeaway. Like documentation, standard of care, doing the right thing. And these stories really do end up boiling down to those pieces. So I think that's a great takeaway.
Yeah.
Wow. Thank you for sharing this. I know there's a ton of listeners and viewers that have wrote in, called in, seen us at conferences and was like, give us a psych story. So this one is something that I think is going to be really, really something. Thanks for sharing that.
I do. I mean, I have several out there. I just have to wait for them to come to some conclusion before we can discuss them. Can't talk about them while they're ongoing. So stay tuned. Right. There will be more psych cases coming.
That's right. Wow. This one was, kind of gave me chills a little bit. Mm-hmm. Thank you for your time, Dr. Miller. Appreciate it. Sorry to hear, the outcome. It's terrible for that guy, but there's a lot of takeaway there. Appreciate you all for listening. We hope you enjoyed listening to these episodes. And if you want to check out more, then head over to FHEA.com. We got all our podcasts there, or you can listen anywhere that you like to listen to your podcast, Spotify, Apple, any of those good stuff. And until then, goodbye for now.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.
Thank you.